President, we can start the program.
So, Deepu, Ramana sir, തുടങ്ങാം. Anoop sir. Okay, 11:32.
Yeah.
So, respected our beloved faculty, Dr. Anoop Kumar AS, KDC President, Dr. Shaji K. Joseph sir, who has Dean Dr. Anil Kumar S, our State Secretary Dr. Deepu, Ramana sir, CD Chairman Dr. Faisal, our IDA CAN Secretary Dr. Dinesh, our Technical Head Dr. Unni, other office bearers of IDA Kerala State and dear members of IDA Kerala State. A warm good morning to all. As coronavirus strengthens its virulence across the world, more than 2.8 lakh people sacrificed their lives before this pandemic. It is the need of the hour of each and every dentist to keep abreast with the knowledge of this pandemic. Now, more than 45 days over, with the lockdown, we dentists are all in a state of anxiety and fear. This deadly potential virus affects almost all areas of our life. We salute all the frontline warriors, health professionals, government authorities who fight against this deadly demon coronavirus. Now, our Chief Minister, Mr. Pinarayi Vijayan, and Health Minister, Srimati Shailaja Teacher, striving hard to set an example as Kerala model to the whole world. Hats off to Chief Minister and Health Minister and their health team for doing wonderful things for Kerala. Now, more people are coming to Kerala from foreign countries, from neighboring states. So, we should be more vigilant against this virulent virus. Corona will stay here for some more time. So, let us arm ourselves and face it wisely. In this lockdown period, we dentists, we are acquiring knowledge through webinars and hibernating in our own nests. In this corona pandemic episode and the post-corona, the dental treatment scenario has to be changed. We need to change our practice modalities. A behavioral and structural changes needed in our practice pattern. Now we are facing a global health crisis. Coronavirus is abundantly present in the nasopharyngeal and salivary secretions of the affected patient. So, we dental health professionals act intelligently, not only to provide care, but at the same time prevent any nosocomial spread of infections also. So, today we have with us an eminent faculty, Dr. Anoop Kumar AS, Chief of Critical Care Medicine, Baby Memorial Hospital, Calicut, recognized for Nipah detection and the containment activities in 2018, which is the only reference we have against a virulent attack in Kerala. So, the doctor has received the Best Doctor Award by IDA Kerala, Government of Kerala, and now actively involved in the COVID prevention activities and as a member in expert advisory panel of Kerala government. So, on behalf of IDA Kerala State, I extend a warm welcome to this webinar, sir. So, IDA Kerala State extends a warm welcome to our ever-loving mentor, our panelist, Ramana sir, former principal, GDC Calicut. And IDA Kerala State also extends welcome to Dr. Shaji K. Joseph, President of Kerala Dental Council, as our panelist. We extend a warm welcome to Anil Kumar sir, Dean of KUHAS, to our panelist. And IDA Kerala State recently released COVID-19 guidelines. Our CAN Secretary, Dr. Dinesh KR, is the man behind that. A hearty welcome to Dr. Dinesh KR as a moderator to this function. Also, I extend warm welcome to all the office bearers, Dr. Deebu, our secretary, CD chairman, Dr. Faisal, technical team, Dr. Unni, and other office bearers and other members of IDEA Kerala State to this webinar. Let us extend sincere congratulations and gratitude to the CD wing of IDEA Kerala State and all the participants of this webinar. So stay inspired with the most relevant topic of the day. So let us know more about our enemy from an eminent faculty, a research personality, Dr. Anoop Kumar AS. Thank you, sir. Welcome to this function. Thank you. Thank you, one and all.
Thank you, Joseph sir, for a kind introduction and nice words. And this is, I think, the second time I am getting associated with an IDA event, an educating event. The first one was in Calicut, I think, during a West Nile fever outbreak. So that time I got an opportunity to communicate with your members on the antibiotic policies and again other viral outbreaks. So that time we were not expecting a COVID outbreak anyway. Then after that, in Anjarakandi Dental College, there was one more session on antibiotic usage in dental practice. So this is the third time, and again, very nice to be with you in this Sunday morning. So welcome to this event. So,
okay,
can I proceed with the presentation, sir? Or?
Faisal, hello.
Yeah, I'll just introduce the panel.
Okay, okay.
Before that, secretary can have his remarks, please.
Deebu.
Yeah, good morning.
Good morning.
President Dr. Joseph, our faculty Dr. Anoop, the eminent panelists Dr. Shaji, Dr. Anil, and Dr. Ramanovar, sir. Thank you for being here. The moderator for the day, Dr. Dinesh, thank you. And the CD chairman, Dr. Faisal, is the man behind this program. Thank you all for attending this program, which has a lot of significance today, especially in a situation where we need to understand whom and what we are fighting. We have created a comprehensive guidelines for the members of IDEA Kerala State, for the dental profession in general. And today's session, I believe, will have a lot of significance because it will throw light on the enemy, what is the, in a popular term, the guest virus that we are fighting today. Because this virus is not from our land, it has come from another land. And we need to understand the guest and what it is. And that is where our eminent faculty, Dr. Anoop, will throw light in. So I should thank you all. And this is a lot of significance in relation to the guidelines which was created with the help of all the panelists and our moderator, who was the man behind that. So I request all the attendees today to listen carefully to what Dr. Anoop has to say and to use it in our practice. Thank you all for being here and wishing you all a happy learning. Thank you.
Respected President Dr. Joseph CC, Secretary Dr. Deebu Matthew, Faculty of the Day Dr. Anoop, other panelists, Moderator of the Day, and my dear IDA members, a warm good morning to all of you. I have been entrusted to introduce the guest of the day in this series of webinar, Know Your Enemy, all about COVID-19. Dr. Anoop is very familiar to us. He is working as the Chief of Critical Care Medicine in Baby Memorial Hospital, Calicut. Dr. Anoop was recognized for Nipah detection and containment activities in 2018. He received the Best Doctor Award from Kerala government and also the Kairali TV Best Doctor Award for Nipah-related activities. Now, he is actively involved in COVID prevention activities as a member of Expert Advisory Panel of Government of Kerala. We welcome you, sir. Our panelists for the day are Dr. Ram Mohan sir. He was a professor of oral pathology and former principal of GDC Calicut. Other panelists are Dr. Shaji K. Joseph, who is the president of the Kerala Dental Council. And other panelist is Dr. Anil Kumar, who is the Dean of Dental Sciences in Kerala University of Health Sciences. This program will be moderated by our own member, Dr. Dinesh KR, who is in the charge of IDA CAN. And over to you, Dr. Anoop, for this lecture.
Thank you, sir. So good morning, friends. And again, first of all, I would like to thank IDEA organizers for giving me this opportunity. And as even WHO mentioned, the prevention concept of the COVID-19 that lies in knowing the scientific basis of the disease, like how it is going to affect us, how it is spreading. So by knowing all these scientific facts only, we will be able to design the preventive measures related to our profession. Like if you are a dental surgeon, to know like how to design these activities, you should have a clear-cut idea about what is happening and what is the like scientific aspects about the disease. So I'm just trying to give you an overview, like the situation of the disease in the world, in India, especially in Kerala, what is the present situation, and again, like how it spreads, some infection control measures. I'm not going to touch in detail about the dental aspects because I've seen a guidelines prepared by an IDA. It is an excellent guideline. Like each word and in that is very useful and scientifically prepared, and even the hyperlinks are given from where the points are taken. So I think they will be sharing that document to all the IDA members. So I don't have to repeat all the things what is like already mentioned in that document. That is why I've just excluded all those parts. And during the panel discussion, we can discuss about all those things. And using this platform, as you can see, you can see in the down, like the question Q&A, and again, there is something like a chat also you can see here. So either by using these things, you can give your comments in Q&A. If you have any specific queries, you can keep typing that towards the end. The panel will sort it out, and we will try to discuss with the help of eminent panelists here. In the chat you can put the suggestions during the presentation, like during my presentation, any slides or any areas I'm covering. If you have any doubts or if you want more clarification on that, please put it on the chat window so that I can clarify then and there. So with these we will move on to the topic per se. I don't think you need any introduction on these things because the disease per se, now it is called COVID-19. Because initially it was called novel coronavirus because this is a new coronavirus. And this is only the disease. The virus is called SARS coronavirus 2 because we had a SARS disease before, and that was also a coronavirus. So this is almost mimicking the SARS virus. That is why we call it as a SARS coronavirus 2. So the disease is COVID-19 and the virus is SARS-CoV-2. Now coming to the coronaviruses, we had so many coronaviruses, but among that, 6 were significant. So these 4 were the common coronaviruses which were producing common cold and upper respiratory symptoms. Then we had SARS coronavirus way back in 2002. Then after that, in somewhere around 2012, we had MERS coronavirus in the Middle East. And now we had this SARS coronavirus, which was initially called novel coronavirus. So these are the 7 coronaviruses that is affecting human beings. There are many other coronaviruses that can affect animals and sometimes can produce symptoms, sometimes may not produce symptoms as well. I'm not going to the in detail about the things what has happened initially, but as you are all aware, the disease was started in Wuhan, a city with almost 11 million population. So the doctors in that area noticed some unusual viral pneumonia in a group of people who had visit to a seafood market there. Then later on, like all the routine viral screening for those group of patients were negative, and by about January 8th, they identified this as a new coronavirus, and even it was declared by WHO. And even the sequence of the whole the whole viral genomic sequence was declared to the whole world. So that is how the disease started. Then gradually the disease has spread to the neighboring cities like Seoul and Hong Kong. And here actually these cities were initially to contain the disease, the China closed down these cities. So that was a shocking news to the whole world and especially to the medical community, because we have not heard about like a city being closed to contain a disease, or a country or a state being closed. So the China took a bold step at that decision, sorry, at that point, and it was extensively criticized at that point, whether closing down an area is really going to harm the people by increasing the mortality and increasing the spread in that area, or really whether it is going to help us. And even it was debated in such a way that they are sacrificing the lives of people in Wuhan and these three cities to save the other part of the country, and again this Hubei province. But later on, it was proved that that is the correct method of containing the disease, and now world over this is being practiced. And this was the connection with the Wuhan market. I've already told the Wuhan and Hainan seafood market. So initially thought that this was like spreading from some snakes. Then later on thought it is from somewhere from the bats. But from the initial paper itself, you can see the red one is with the persons exposed to the market. The blue are one without exposure to the market. So you can see almost half of the initial patients were not exposed to the market at all. So this point is still unclear whether the disease has started in the market itself or before. I'm not going to the controversies about that, but this point we all should know. Then, because of the globalization, the disease which was started in Wuhan, within few weeks it started spreading to different parts of the country, because the Wuhan was a travel hub of China. It was connected through air, road, and the rail with other parts of the country and across the world. So immediately after like this disease was declared, before this travel was completely banned, the people started moving around, and even in Kerala, we had almost 3,500 people returning from China, and mainly from the Hubei province. So from out of that 3,500, mainly medical students returned to the state, we identified the first case in India on January 30th. So that is how it was started. And the cycle of the disease is usually we will be having an imported cases followed by like a case usually imported from the countries. That is the stage one. Then we will be having a local transmission. This is a phase where we are lying now. We are in the present situation. And when we have the community spread, that is the third phase, and there is a epidemic phase. So we will go to that later. So this is the today morning figures. So few days back, like when the China was affected, when they were reaching 10,000, 20,000, and when they reached 80,000, the whole world was looking uh, like in a panic way that China got 82,000. Now see the situation. China is in the you can see 10th position. So there are 9 countries who has already reported more cases than China. The US has almost reached 10 lakhs. Then you can see the other European countries, UK 1.6, Germany 1.5, Turkey, Russia, and unfortunately, India is also heading towards the initial first 12 countries. So this is these figures are not updated from India, I think. So altogether, we have almost 30 lakhs cases across the world with 2 lakhs deaths. So this is spreading all over the world. So you cannot keep away from this disease. That is what we are learning from everywhere. And one more point I wanted to stress at this point is the Singapore was actually projected world over the way now the Kerala is projected as the best model of prevention, because they had experience in dealing with SARS before, and they've nicely contained the disease. But even they are not able to contain the disease, and they have reached numbers of 16,169, and even the community spread is suspected in that country. So that is the situation world over. And you can see that Russia is also heading towards 1 lakh. So Russia was a country who was ready to go and help the US with all the medical equipments. So even they are affected. But there is some strange thing what you can observe. See, even Russia, when they are reaching 1 lakh, the mortality is only 300 here. But US, it is almost 56,000. And even UK, when they have affected only 1.6 lakhs, they had 21,000 mortality. And India also, the mortality is comparatively less like compared to some other countries like Italy. So there are many factors in that which we will not discuss in detail. Coming to this diagram, you can see the cases was initially starting like this, spreading over to different parts. Then you can see it was coming down. The whole trend is actually narrowing down. So that is a good trend. It is getting contained, but different countries are having a different pattern. I'm not going into the details about that. And again, you can see the countries like US, they are the plateauing the curve. UK also, Italy, all the countries are plateauing. Now, mainly India, Russia, and Brazil. These are the three countries with an exponential growth. So that is why the numbers in these countries are increasing. Obviously, I think India, we will hope that India can plateau the curve, but all other countries have really plateaued the curve. And the China, you can see how beautifully they have touched the bottom line, but still the cases are getting reported there. So this is the present situation here. You can see the total cases like as on today morning 8:30, 62 cases are the 62,000 cases are there across India with 41 active cases and 20,000 have recovered, and the total death is almost 2,000. And you can see the states like Maharashtra, they have very badly affected. The total numbers are 20,000, and the death is also very high there. You can see the Gujarat, Delhi, Tamil Nadu, Rajasthan, Madhya Pradesh, Uttar Pradesh, Andhra Pradesh, all these states are very, very badly affected. But here you can see, I have told you, we are the state who reported the case in January 30th, and we were the first position like few weeks back. From there, we have like almost, we are now in some 13 or 14 position. So this is the importance of having proper containment. And here you can see how beautifully we contain the disease in our state. Like we have almost touched the baseline without much active cases, even, and the confirmed cases also, we have really plateaued that. So this is because of the excellent effort by the state government, the health department, and obviously by the public participation. Without public participation, you cannot attain such a beautiful graph and containment. So we should know how we attained all these things. That is very, very important, because now we are all discussing about the people who are coming back from Gulf countries, whether we can accommodate them or are we going to lose our control. So before that, we should know how we attained all these things. And again, that time we were not quarantined. The quarantine was not done in the quarantine centers. They were allowed to go home, and even some people didn't adhere to the quarantine policies as well. So how it was done? Extensive quarantine contact tracing. The experience with Nipah really helped us. We have at one point of time, the number of quarantine people were somewhere around 1,80,000. The quarantine adherence was assured with the help of the healthcare workers and even the Janamaitri police. The testing was done appropriately, because even now the Kerala was criticized for doing lesser number of tests. Then how we attain a best outcome? It is by doing the test for the most appropriate people, and again not wasting the test, and early detection of the cases. The mortality was very, very less, because all the cases were detected from the quarantine area itself. They were immediately shifted to the hospital. Any minor change in their variation in terms of like oxygen saturation, symptomatology, etc., was detected early, and they were given appropriate care. And as I've already, the last slide, appropriate care was initiated at the proper time. It is not that a new treatment was tried in Kerala. All over the world, these experimental treatment was were carried out. So we were also doing the same thing, but it was done at an appropriate time. So these are the measures by which we were able to touch the line to the bottom. And with this experience, I'm 100% confident that even if more people are coming from the Middle East, we will be able to contain the disease. See, this is the one. This is the why we were we were criticized. As you can slide, you can see like the Kerala was 1 in 500 per million population testing, and there were countries like Iceland with more than 1 lakh per million testing. Even with that lesser number of testing, we were able to attain a position which is much better than the country which tested more than 1 lakh per million. So that is how you have to apply the scientific knowledge in the prevention aspects. So to see how beautifully we have touched here in Kerala, the total active cases are only 17 now, and we have tested only 40,000. We had 505 confirmed cases, and you can see the active cases is almost touching baseline. And again, the active cases are also getting plateaued. So, and again, so now we have almost 505 patients. 23,000 people are under observation, and 34 in hospital, and 23,500 in home, and 123 suspected persons are hospitalized. We have 17 active cases. So what we should know here is we had almost 360 persons returned from Middle East, and from that 360, usually by this time, even if you take all the measures, it should have been somewhere around 10,000 or even more. That is what we have observed in other states. They were not even having 360 imported cases. Maybe Tamil Nadu was having more than 1,000. Other states were not having these many number of imported cases. Even with these all like these many imported cases, with the proper containment measures, we were able to contain it to 145 numbers. That is why the total number were reached to 505. So in from Nizamuddin also we had these many patients, only 18 tested positive from 120. So this is the present status now. You should all look at these maps. Different maps are available in the website. So we are dividing it into different zones: red, green, orange, etc. And this is basically for the administrative purpose. Don't confuse it with the medical things completely. So how to do the different administrative aspects in this area. These areas, districts were designated. We have Kannur and Kottayam being in the red zone now. And there are many hotspots also, which you can, with the help of these graphs, or if you go to the Government of Kerala website, you can know like which are the hotspots. So these hotspots will be having severe restrictions, and it is better to take more attention to the persons coming from like hotspots, especially in terms of dental procedures. Now coming to the disease per se. So first thing what you should know about the epidemiology is there is a secondary infecting rate, or the productive index. We call it as R naught value, even though we write it as R0, we read it as R naught. So R naught value. So usually in COVID-19, it is about 2.5. That means one person can infect almost 2.5 persons. So this is how the disease will be exponentially increasing. If the value is only 0.8 or 1, the numbers will be gradually coming down. So your aim should be, with all the preventive measures, you should be able to reduce the R0 value to less than 1, so that the progression can be prevented. So how we can reduce the R0 value? This is what we should know, especially as healthcare professionals, and we should be able to explain to our friends and relatives as well. So reduce the susceptible persons. So who are the susceptible persons? Without any immunity, they will be susceptible. So how can we get the immunity? You have to give a vaccine, but we don't have any proper vaccine. You can debate that the persons with herd immunity won't be having the disease, but again, still in a debatable situation. We don't know whether these diseases are going to really make an herd immunity, and how long that will be protective. That depends. We have to wait for further reports. So here the vaccine is not an option for us. Then you can reduce the viral load in a patient by giving a proper antiviral. Many drugs are tried, even antiviral drugs are tried, even other a group of drugs are tried, but even at this point, none of these drugs are found to be very effective. So if you have an antiviral drug, you can immediately reduce the viral load and the spread can be prevented. So only option left with us is the non-medical public health interventions like quarantine, isolation, social distancing, and behavioral changes. This is the point where we all should stress. And the behavioral changes should be applicable to all persons in the medical field. One fact we all should understand is we are not going to stop this disease. That is impossible. The complete eradication of the disease at this point sounds very illogical. So only point possible will be you can contain the disease and we will have to live along with the disease. So for that, you should make the behavioral changes. Like there are many things, including the hand hygiene, like other infection control measures, and many other things. So one important thing as dental surgeons, what you can practice is, like I'm a doctor working in an ICU. So the one thing we always do is the bare below elbow policy. You can see, like we never, I'm not in the ICU now, but still we will always keep the below elbow without any ornaments or like watch or even the sleeves. We tuck like we tuck the sleeve and again keep like that. So these policy we can adopt for all dental care practitioners as well. So how these diseases are spreading, if you see, uh, this is something called a flattening of curve. We have a maximum number of patients who can be accommodated. So if the numbers are increasing exponentially, we may not be able to control that. And to with the containment measures, we should be able to delay the peak and we should try to flatten the curve. Okay, so that means you may not get a peak numbers and your hospitals will not get filled up like in Italy or now happening in Mumbai. So this is how we should reduce the number. So we cannot like reach a point where it is completely touching. Even in Kerala, even though we have touched, obviously as the outsiders or like the persons are coming from other affected areas, obviously we may able to or we may be increasing the numbers. So this concept should be very clear. And again, this is other concept about the disease. When you plot the time course about the severity of illness, you have a initial viremic phases which gradually slows down, and in this viremic phase in the initial days will be having maximum infectivity. So, and as the symptoms advances, it is basically because of the inflammatory response. It's not because of the proper viremia. So even if the patient is very sick with the lung findings and other organ failures towards the end of 10th day, it is basically will be the inflammatory response and they may not be very infective. So based on that, you can divide the cases into different classifications and the severity also will be like progressing that way. So initially the patient will be having only mild symptoms progressing into breathing difficulty and severe respiratory failure. And the treatment and the signs are also designed accordingly. Now, this classification also should be very, very clear. Like you have four groups of patients here. One is without any symptoms, that is up to 30%. Those with mild symptoms, which belongs to almost 55%, and with the severe symptoms, which is almost 10%, and the critical illness patients, which is almost 5%. So the mild symptom patients will not be having any symptoms at all, but they will also develop immunity. Okay, they will be infecting for the initial few days, but gradually their infectivity will come down, and if you do a PCR test, that will be positive during those days. In mild symptoms also, initially they will be also having an asymptomatic phase, progressing to the mild symptoms sometimes which we may not be able to detect, and they also will become immune, and their infectivity also will be like this and can be tested positive accordingly. And the 10% of patients you can have severe symptoms requiring hospitalization, and they will also become immune. So here the issue is, you can see the hospitalization is occurring at day 9th or 10th. Till that time, they will be having only mild symptoms. Okay. So though even those who are recurring in hospitalization, they may be stable in the initial days, and they also will be having a phase with no symptoms. So what you have to understand is these no symptom phases are there in all the groups. Even in the severe group also, they are having a no symptom phase progressing to the ICU, and half of them will die, the severe patients. So the asymptomatic phases are there in asymptomatic group and all the other symptomatic group as well. So here, what you have to, the infectivity also will be like that. From the no symptoms to the mild disease, the infectivity will be persisting. Now, if you see the other parts, like the patient will be having fever and cough. After this is the point from where the person is exposed. Then the patient is developing fever and cough. Then the patient will be having dyspnea later, and the infectivity will be usually from like mainly from day 2 days before, and again it can last up to 10 days. Okay, so this is the area where you have to suspect more. Even I don't know like whether I am going to develop symptoms after 2 days, and your patient also, you may not be knowing that whether they are in the pre-symptomatic phase. So that is a main challenge. And to know the infectivity, actually, you have to do a viral culture and isolate the live virus. Then only you will be able to say that the person is really infective. Your PCR positivity, because this was the point which was discussed extensively in the media, the patient, the PCR getting tested positive on day 20 or even day 30, and there are literature reports for PCR positivities up to day 62 days. So keep in mind, having a PCR positivity will not correlate with the infectivity. We are just detecting viral fragments there. That doesn't mean that the person is infective. And the same way, you have the antibody will be developing from day 3 or 4 of the symptoms. But even before the antibody is getting developing, you will be having a phase where the persons can be infective. That is why even the persons who are returning from Middle East, even if you do an antibody test, you may not be able to detect the persons at this point, and obviously they can become positive at a later time. The same way, and IgG will be developing at a later time. And if you have an IgG also, that also doesn't tell you that the person will not be infective, because he can be in this part where he continue to be infective for a few more days. And the incubation period means that is from the time of person exposed to the time of symptom development. Okay, so by doing a PCR test on day 40 and showing the PCR positivity, you cannot say that incubation period has extended up to 40 days. Incubation period is only up to symptom development, and that is always less than 14 days. So this is the incubation period. There are many studies where everywhere it is shown somewhere between 2 to 14 days. And as you can see, the maximum number of infectivity is happening between day 4 to day 6. That is why now the Kerala is adopting for 7 days the institutional quarantine and another 7 days in home quarantine. Because if one person is like carrying the virus, they are likely to show the symptoms within the 7 days, or even if they are getting infected during the flight or during the travel, they are likely to show the symptoms in first 7 days. So this is the scientific rationale behind the present Kerala state decision. So this point I've already discussed. Even after the onset of symptoms, they can stay very mild symptoms, later on go into severe symptoms. This is very, very important. As a healthcare worker, you should know that these are the data from China. You can see this blue are the number of persons getting infected. You can see the number of persons getting infected are mainly from 40 to 40, 30 to 39, and up to this group, because these are the persons who are going to interact with the public more. Okay, so if you are an younger age, doesn't mean that you will not get infected. But see, if the age is more than 65 or more than 70, the mortality is very, very high. That is why we should try to keep these persons away from such fields. Even the dental surgeons who are practicing, you should definitely keep away from the aerosol generative procedures, because if you are getting infected, the chances of dying will be very, very high. So in your house, you should try to do the reverse quarantine. In your profession also, you should try to do the reverse quarantine. And this is the way by which you can reduce the mortality. So you should be very, very clear about this concept, I feel. Now regarding the transmission, as I've told, the pre-symptomatic transmission is happening in 45% of the patients. Okay, so this is mainly those who are having symptoms also will be having a pre-symptomatic phase. Then we will be having a symptomatic patient spreading 40%. Then later on, the environment is spread. That is very minimal, like the place where you touch, someone else touches there and getting infected. Those things are very minimal. And the so-called, so much discussed asymptomatic group, they will be spreading very, very minimal 5%, because they don't have that much viral content in their secretions. Okay, so you should be concentrating on these pre-symptomatic phase and the asymptomatic 5, because altogether these asymptomatic patients constitute 50%. So these people are going to be the real challenge in the healthcare sector, because we cannot identify these patients without doing a proper testing.
There's a question being asked.
Yes, sir, please.
Yeah, from Shamsul Huda. She asked that some reports say that the virus is spreading even after 28 days. Is such a thing possible?
No, that is why you should not getting confused with the viral spreading and the PCR positivity. The PCR positivity is entirely different. That is not a surrogate of infectivity. The surrogate of infectivity is either a viral culture or there is something called a subgenomic mRNA PCR. So till now, no published papers are there where the virus isolation has happened after 10 days. Only one paper has shown that on 18th day they were isolated the virus. That is only only one case isolated report.
So that means, yeah, if a person is positive in the PCR test after 28 days or 30 days, doesn't mean that person is infective. So that's what.
Sure.
Yeah.
Only initial 10 days only a person can be infected. Okay,
yeah.
we will discuss that later. So
Okay,
coming
sure.
to this slide again, this is very, very important. As a dental surgeons, you should be very, very clear about that. We are all worried about the airborne spread. See, even this is a COVID patient. The airborne spread means depending on the droplet size. If that size is more with the more something like more than 50 microns, they will settle within 1.5 meters. Okay, they cannot transmit more than 1.5 meters. So if the particles are very small, they can get suspended in the atmosphere and can travel up to 6 to 10 meters. Okay, so even if it is a airborne infection, that cannot transmit the disease more than 10 meters. But as a dental surgeon, what you should understand is, if your clinic is a closed space, even if that the patient like if you make some droplet, that droplet can get suspended in the atmosphere, and even after some time the person coming to that area can get infected. That doesn't mean that if you are doing a procedure in one room, the next room person get infected. It should be very, very clear. The transmission distance cannot be more than 10 meters, average 6 meters. And this airborne infection is a doubtful thing. WHO has accepted, CDC has also accepted, but still the main mode of transmission is droplet spread. So our concentration should be mainly on droplet. So obviously we should be able to do the airborne precautions also when you are doing a aerosol generated procedures. But to the prevention part, we should be concentrating more on droplet preventions, which I will come to later. So these are the symptoms which already your guidelines is also clearly mentioning. Because of shortage of time, I'm not going in detail, but keep in mind, you can have like an infected person without fever as well. Having a fever is it is not necessary that the patient should have fever to have a COVID. You can have a COVID patient without fever as well, and there are many other symptomatology as well. This will be available in your YouTube. You can see that later as well. So coming to Dinesh's question again, see, this is the days where the patient is getting infected. Your infectivity will last only up to 3 days before the symptoms and maximum up to 10 days. The PCR positivity, this is what you are telling the virus is isolated. It is not the viral isolation. The viral particles are detected. So that can go up to 62 days as per the reports now. 62 days of PCR positivity also has been established, but the infectivity is unlikely to last for more than 10 days. Okay, so your all policy should be based on that. That is why we have also changed the discharge criteria based on that. So previously it was test based, like only if PCR is twice tested positive, the persons were discharged. Now it is symptoms based and time based. Like after a PCR is being positive, you can wait for 10 days, and if it's asymptomatic, you can discharge based on the symptoms. Like if you're having a symptoms after 10 days, last 3 days, if he's asymptomatic, he can be discharged without further PCR. So now the discharge policy is based on symptoms and the time. It is called time based and the symptom based discharging strategy, that even our country has adopted that. This is regarding the symptoms. I think Dr. Dinesh has given a beautiful link in your document. Please take that. Now coming to the testing part. So as healthcare professionals, you should also clearly know what is this testing, because this rapid antibody testing, all those things have created so much confusions, especially in Kerala. And again, regarding the before like mentioning about the testing, you should know where and all the virus can be isolated. The first thing, these viruses are getting bound to a receptor called ACE2 receptors, and these receptors are seen in respiratory and GI tract. So the patients will be having virus mainly in respiratory and GI secretions, and the symptoms also will be mainly on these systems. And the maximum concentration will be in the bronchial fluid, followed by sputum, nasal swab, pharyngeal swab, etc. The feces and blood, the incidents are very, very minimal. So this is a very, very important point you should all know, because see, this is the nasopharynx lies here. I think you will be knowing better anatomy than me regarding the nasopharynx. And when we take a nasal swab, we should try to get the swab from the nasopharynx. by going through the floor of nose, then reaching the nasopharynx. So why I selected this picture here is, see, there are many arguments in your groups. I have also seen that if you do a mouth gargling with some some preparations, like even a chlorhexidine mouth gargle, the viral load can be reduced. It may be true that the load may be slightly reduced, but see, you cannot reach the nasopharynx by using the gargling. It is not possible. Okay, and even if you put a nasal drops, you will have to irrigate the nose with a huge quantities of chlorhexidine. But even then, these viruses are bound to the receptors. You cannot kill all the viruses. So giving some antiseptic solutions and killing the virus, that will be it will not be a scientific idea. In your common sense, that may sound good. That is what even the American president was saying, to inject all the persons with these antiviral solutions or antiseptic solutions. So that is in common sense, that may sounds like that, but in scientific aspects, when you consider, it is impossible. So now coming to the tests again, you can either detect the virus or you can detect an immune response to the virus. The viral detection can be done either by a nucleic acid test or by viral antigen. So in the world, the viral antigen tests are being like in an experimental stage. None of the tests are approved by any authorities. Antibody tests are two types. You can have not basically three types. You can have a CAR test, you can have an ELISA titer, and there is a neutralization test as well. This nucleic acid is usually by PCR. Different methods of PCR are there. I'll just go through that like a bit. So this is the rapid test where you put the drop in the a drop of blood in the cart, and you will get a like a line there. I will explain that. So usually when the patient is becoming symptoms, so the symptoms will appear and gradually will settle down. And so this is the like RNA detection. So RNA, the PCR, if you do from the before the symptoms onset itself, you can test that. Then later on, the IgM will become positive. Maybe a slight delay between the symptoms and IgM response. That is why even if you check the travelers with the CAR test, you can miss the persons in this area. And later on, they can develop other like symptoms. So this is the usual CAR test where you can see a line there. So put a drop of blood there, then you will get a CAR test positivity. And these are the different proteins the virus is having, like a spike protein, envelope protein, membrane protein, etc. Why knowing this is important is, the antibodies are developed against all these proteins. So still we don't know which antibody is really protective. We assume that the spike protein antibody is protective, extrapolating the data from the MERS studies. Still we don't know that this spike protein antibody is really protective. And there are many targets of the gene. So in the PCR test, you will be looking at different targets. So basically in a confirmatory test, you screen with one target like an E target, and a confirmatory with an RDRP or ORF1 or S. Okay, very simple. You have to look at two different genetic gene target to confirm the test. For a screening only, you can test like a envelope gene. So envelope gene, nucleic capsid gene, or like RDRP gene, and again, or many genes are there. So just an overview. So whom to test? We cannot test everybody. That is what you all should understand, because there is a national ICMR protocol. So whenever they approve any lab, they're taken they will take an undertaking from the lab saying that we will be testing only the persons as per ICMR guidelines. So as per ICMR guidelines, a person's within with an international travel in last 14 days with symptoms. This now may be like outside states also we can include, or symptomatic contacts of lab confirmed cases. Symptomatic healthcare worker. If you are really becoming symptomatic, you are eligible to get tested because you are a healthcare worker. All hospitalized patients with severe respiratory infections, like anyone developing a severe pneumonia, should be tested. Or if patients are like asymptomatic, but they are having a direct contact with a confirmed person, even if they are asymptomatic, they should be tested between 5 and 14 days. Okay, these are the persons whom we tested at day 48 or something. That okay, we cannot test them like after 14 days. We should have tested between 5 and 14 days. And now in the hotspot area, you can do like testing for all symptomatic in ILI. ILI means influenza like illness, fever, cough, sore throat, or a running nose. So with these symptoms also, the persons from hotspot should be tested with the PCR initially, or like the second week antibody, but antibody tests are not available at this point. So regarding the infection control measures, we should try to limit the human to human transmission. That is the first importance you should give. You should reduce the secondary infection. That means from the infected person, it should not go to another person. And prevention through the amplification and super spreading events. That is especially the healthcare area. So you should not be a focus of these infections. And the most important thing is cleaning hands. So as a dental surgeon, this is the most important thing you should give importance. After touching and before touching all the patients, you should use a proper surgical hand rub, or you should do a hand wash. So coming to your organization, what the organization can do. So you should identify the hazard the way Dr. Dinesh and team has already done. Then you have to assess the risk as a healthcare workers. What are the risks involved in your that? How can you control the risk, especially reducing the aerosol generating procedures, taking control of the persons from the hotspot, and again, how to review and maintain control measures. Like a body like yours should continue to review the guidelines and should maintain the control measures. The guideline what you publish today may not be applicable after a month's time. So you will have to keep on reviewing that. So this is the policy for any hazard when that is infecting us. So what are the things what we can do? We can eliminate that hazard. We can substitute that. You can make engineering controls in your clinic. You can make some administrative controls the way we have already suggested by the IDA, or you can have the personal protection equipments. So physically removing the hazard, it is impossible here. Substitution, we cannot replace this hazard. That is also impossible. So these things we should understand is a reality. We cannot eliminate and substitute. So what is possible for us only? We can have engineering controls, we can have administrative controls, and we can use the personal protection equipments. So coming to these 3 points, what we can do. Regarding the engineering controls, you can, like isolation rooms or some, that is basically in the hospital setup. But in a clinic setup, you can avoid the closed rooms. You can make it more ventilated. I know that many clinics are already closed. You don't have enough ventilations, but if possible, like even the operation theaters, we are suggesting that. So if possible, keep the windows open, have an adequate cross ventilation so that the airborne, which I've already told, the airborne infective materials can be reduced. The administrative controls, like you should, the engineering controls should also include the barriers, like which I've already discussed. You can have some goggles or the face shields to reduce exposure. And the ventilation systems. Even if you are having a AC, you try to reduce the recirculation if you are in a bigger hospital. Like the air should not be recirculated, and that air should not be sucked from one room and again go to other areas. Especially if you are a maxillofacial surgeon or something, if you are having a clinic. So, and if you are working in a hospital, the air sucked from that area should not go to a different area, because if this patient is getting an infected patient, definitely these can spread to other areas. Okay. Another simple thing what you can do is, like especially to convert your clinic, you put an exhaust fan in your clinic. So even if you keep an AC on, your electricity bill may go high, but this exhaust fan will keep on changing your air in the room, and again will definitely reduce the airborne particles there. So putting an exhaust fan in the clinic also will be a good idea, or keeping the door open and again keeping an exhaust fan in the other end. Now coming to the administrative controls, like we try to reduce the number of persons involved. Like even if you are getting a patient inside the clinic, you tell that only patient can be allowed. Don't take any relatives or bystanders to the clinic. I do admit that if the patient are like sick or need support, or like pediatric group, that may not be possible. But you should use your thinking process at that point. I think that has been also very clearly told. The visitors should be reduced. The source control should be done properly, like the PPE, all those things. You should like follow the image protocols. Then the healthcare workers also, if you are having symptoms, you should definitely keep away. I have told, as a healthcare worker, if you are developing symptoms, you should get tested. And again, if the proper time itself, you have to do the testing. Regarding the PPE, again, it's nicely given in your document, like which are the procedures where you have to do the PPE and N95 mask. So what I suggest is, do you go with the same guideline? And if it is an aerosol generating procedure, you should use an N95 mask. And even if the proper PPE is not available, even in our ICUs, like I'm working in a ICU, even in our ICUs, we are not getting proper PPE. So the best substitution will be, as many of your members have already put in the social media, you put a normal surgical gown. So that will definitely help you. But the same surgical gown, you cannot keep it till the evening, because the outside part will be already infected. So you should not touch that. So maybe for a few patients you can use that, but obviously the cross contamination issues will be there. Ideally, you should use only for one patient. I don't know how practically we can decide that during the panel discussion. I think we can take that point. So N95 mask, which all areas to be used, you should know. And the difference between surgical and N95 masks, there are many differences. I'll come to that later. So you should know how these pathogen, what are the reservoir, there is no reservoir here. And again, the portal of exit, I've already told where the virus is. And again, the transmission, how the transmission is happening. Then the portal of entry, it can enter either through the GI or through the respiratory tract, or from the conjunctiva as well. So you should have a clear-cut scientific evidence about that. The susceptible host, I've already told, who are the person who are likely to become more sick with the symptoms. So all these ideas, you should have a clear-cut knowledge. So once you have a knowledge about all these things, so keeping away from the disease is very easy. Coming to the standard precautions, very beautifully given in your document again. I'll just go through once again: hand hygiene, personal protective equipments, respiratory hygiene. If you have a cough or something, they should cover that. And another thing I wanted to highlight: even if you are getting a bystander to your clinic, they should be always using a mask. They should not be allowed without a mask inside your clinic. I'll explain that again. The safe injection practice, sterilization, environment cleaning, all those things. So the transmission-based precautions are mainly for contact precaution, droplet precautions by, again, mask, airborne precautions. Sorry for the figure. That figure, it should have been an N95 mask here. So here, airborne precaution, mainly you use an N95 mask. Droplet, even a surgical mask is enough. A surgical gown is enough for contact precaution. So a contact and droplet precaution is enough in majority of the procedures. But like an aerosol generating procedure, you need a like airborne precaution also. Mainly you need like an N95 mask. This diagram we have already described. This is again like the droplet in the droplet, and again the way how it spread, two ways, which I've already mentioned. Now, this is another doubt everyone is having. Why we are like advising universal masking for everyone? I'll just finish in another 10 minutes. So here again, what you should understand is, I've already told the main mode of spread is through the droplet, and we have 50% of asymptomatic spread, including the pre-symptomatic persons. So to cover, again, to prevent the spread from that group of persons, if you advise them to use a like even a normal cloth mask, all these droplets will be filtered at this point itself, and they cannot spread the infection, because being asymptomatic, their viral load will be low, and as they are asymptomatic, they won't be having any aerosol generation also. So in that case, by putting a normal cloth mask, you will be able to prevent the spread from these group of persons. That is why the universal masking should be advised, and it is not to protect yourself, and it is basically again, you should to prevent from you to infect your friends. Okay, that concept should be understood. This is again, which I've clearly told before, the main concentration of the virus is in the nasopharynx. It is not in the oropharynx. And again, there is a reservoir in the respiratory tract as well. So whatever the solution you use in the throat, you cannot reduce the viral load. It is impossible. Okay, maybe viral load a little bit may be possible, but you cannot eradicate the virus. So that concept should not be practiced. The mask can definitely reduce R0 value. Even the European countries like Czech Republic, they have really showed that. Like many countries have adopted the universal masking, and they were able to depress the curve very effectively. So universal masking should be encouraged, and as a healthcare worker, you should tell all your friends and relatives that you should not come out of your house without having a proper mask, and a normal cloth mask is enough. Now, This is very, very important. As a dental surgeon, you should have a clear-cut idea about this thing. So what is a respirator and a normal mask? Okay, respirator is to filter very, very minute particles, that is aerosols or airborne infections. So here again, there are different categories of masks. Like if you see, there are FFP1, FFP2, N95, N99, P3 and N100. So this is based on the filtering capacity. Okay, so N95 can filter up to 95%. FFP2 is the European licensing authority. N95 is a NIOSH licensing authority. Okay, an Indian company cannot have an N95 certification. That is actually fake. Okay, if any Indian company is producing an N95 mask, that means they are just making a duplicate. Okay, if you go to the NIOSH site or USFDA site, they have already given like what are the approved or NIOSH certified mask. So it doesn't mean that you should you should always go with a NIOSH certification. You can go with an FFP2 certification. Now what I understand is like ICMR is also trying to make a certification. So if that is available, we should make sure that that certification is there. One thing you should be very careful is there are FFP1 masks available. That is basically an industrial mask with a filtering capacity of only 80%. So that is not advised. And again, you don't need an N95 and an N99, FFP3 or N100, which is having a 100% protection. That is actually not required. If you are having, it is well and good. So different types of mask are there. N95 can have 95% filtering capacity. Here you can see the number 8210. There are different numbers. If you go to the NIOSH site, you can see you should use only the brand with that number, or you have an FFP2 respirator. This is another confusing part. Everyone is having a feeling that if you have a valve like that, that will be having a more efficiency. So what is the purpose of having this valve? This valve will filter when you take the air inside. Okay, but when you are exhaling out, it will not filter. So you will not get a suffocation. So you will be having a better feeling. But what is the harm? So as a healthcare worker, if you are having virus in your throat, or if you are an asymptomatic person, you will be infecting your patient because it is not getting filtered. So you should never use a mask with a filter in a COVID situation. Okay, it should be very, very clear. I think that part we can include in the guideline at a later time. So you should definitely mention that the mask with the filter should not be used in COVID situation. It is to protect the public and your patient, because you don't know whether you will be a carrier. Okay, and there are other FFP3 and N99 which I've already mentioned. There is another certification called CAN certification. This is a Chinese authority. So even CAN N95 certification is also the efficacy wise, it is as good as the Chinese one. Sorry, the NIOSH certification. But the problem is with the Chinese the guidelines, how much you can depend on these CAN certification, I really don't know. But if it is properly certified, and if you can check with the Chinese sites, I think that can also be adopted. And the repeated usage of these masks will definitely reduce the efficiency. I'll come to that. And this is regarding the efficiency of the effect of wearing and the mask infection rate. Even the normal mask, it can have almost 80% of the protection, which you already told a cloth mask. Here again will be reduced. Here the infectivity will be even less. So this is very, very important. As a dental practitioner, you can all start applying this to your practice. Like suppose a virus enters to any inanimate object. If something like a paper, it can last for 24 hours. In a hard surface like steel, it can last for 48 hours. Or in other hard object, it can last in 72 hours. So how can we apply into our practice? You take 4 masks. Okay, so the first mask you use for first day, you put it in a plastic cover and keep it. Don't take it to your home. Second day you use another mask. Third day you use a third one, and fourth day you use the fourth one. Okay, by the time you reach the 5th day, the 72 hours is over for the first mask. So virus would have been completely eradicated from that without having any sterilization technique. So you can very well use the day 1 mask on the day 5 again. Okay, so if you have 4 masks, and 1 mask can be used for 5 days. So if you have 4 N95 masks, for the whole month you can use that. Okay, so this has to be practiced in dental practice. I feel this is not the one created by me. This is created by the like US authorities. This has been practiced in all the ICUs across the world now, and I think it can be adopted in our practice as well. The sterilization technique, I'm not going into the details, it will be a bit difficult. And there are different masks, and again, the filtering capacity. Even a normal handkerchief will be having a filtering capacity of 30%. Yourself and your friend, if is wearing 30 plus 30, it can go up to a 60%. Again, just my assumption may not be correct, but it can filter the droplet and prevent infecting others if you're an asymptomatic person. So if an individual is infected, the droplet can go through the like your hands, the coat, or the other procedures, or can be having a direct contact, or like a droplet, if it is small, can be airborne, and it can also infect others. So see, this is only a very, very minimal part, maybe during an aerosol generating procedure. All other thing, you need a droplet precaution. That is why you should use a proper hand hygiene. The transmission based precautions are again like standard contact precautions, and for any suspected case, like you have to take airborne precautions also. So to points to consider that the patient fulfill the case definition criteria for the disease. So if any contact with that, definitely you should take all precautions, or if your clinic is not having enough facilities, don't take such patients. What type of procedure will be the patient undergoing? I think your association has given a clear cut guideline on that. Where the patient is located, whether the patient is from a hotspot or a returned person, what is the infectious agent, is mode of transmission, which we have already discussed. Is there any risk of contamination, which we have already mentioned, and what type of PPE? So these things should be known. And these are the procedures like bronchoscopy, surgery, tracheal intubation, etc. in our field. And what are the dental procedures with aerosol generation, like it is there in the document. And depending on that, you can decide which are the areas like these N95 masks should be used. Even in the ICU, we are not using N95 mask. N95 mask is limited for the persons with suspected COVID patients. Other patients, like if we are using only a normal surgical mask, and even in US, UK or NHS, only for aerosol generating procedures, they are giving N95 mask. Or even if a patient is admitted without symptoms, a normal surgical mask is enough. And again, one thing you should understand is eradicating this disease is impossible. We will have to live along with this disease. So this is regarding the hand rub and like efficacy. This is just paper I thought like it will be helpful for you as well. Even if you dilute the hand rub, we always recommend it is more than 80%. You can see, like even if it is diluted many times, like even more than 40% will be having an excellent viral like killing power for like even if you use for 20 seconds. Okay, so any surgical hand rub will be like good enough to control these things. Regarding the treatment, I can keep on talking for another half an hour, but again, because of time constraints, I'm not using. But always keep in mind the hydroxychloroquine. Even though recommended by ICMR, it is not having any evidence. The recent studies are all negative about hydroxychloroquine. I will never recommend hydroxychloroquine prophylaxis, even though ICMR has stated that, but that is without any proper homework, I would like to say. And regarding the algorithm of management, what we are doing right now is the patient without any symptoms or oxygen requirement, or patient with oxygen requirement or requiring mechanical ventilation. A patient without symptoms, no risk factors, actually doesn't need much treatment. With risk factors, you can consider hydroxychloroquine or azithromycin, but again, it is debated nowadays. If patient are requiring oxygen like requirement, like the convalescent sera, interferon, etc., can be tried. Or sick patients also, you can use convalescent sera or the antiviral drug like remdesivir or the biological agent tocilizumab. Because of shortage of time, I'm not going too much into the details. So thank you so much for giving me an opportunity to interact with you. I'm really sorry that I have exceeded the time, because I was given some points to cover and I was trying to cover all those areas. You can note my email ID and again personal WhatsApp. If you have any queries like later on also, you can feel free to contact me. We have also have a other platform called Webinar Campus. We have a FP page also. All the talks what we are doing, like again many experts also we are getting every day evening. We have a talk, like sessions on evening 7 to 8:30. So those persons interested can visit our website. So thank you so much, and really sorry for taking so much time or wasting your time.
Thank you, sir. No issues at all. It was an absolutely illuminating session. Sure. There are a couple of questions being asked in the chat box. Can we take it now? Because together with this, yeah, the first one is we answered that regarding the virus spreading after 28 days, and there's another Dr. Pratyusha asking whether COPD patients, chronic obstructive pulmonary disease, those people are more vulnerable to this disease. If so, is there any studies with regard to the mortality rate of this particular set of patients?
Yeah.
COPD patients.
Any patients with a pre-existing lung disease, when they are infected, obviously they will be having more mortality. So such patients also should be shielded. We can call it in different terms, either reverse quarantine or shielding. In UK, they call the term shielding. So they should be kept away from the public so that they should not get exposed. The same way, too much obese persons, all these groups, and again the persons with a coronary artery disease with less cardiac function, or the ejection fraction is less, or patients with a renal disease or any autoimmune disease on steroids or immunosuppressant drugs, all these group of patients are high risk patients, and again persons more than 70 years. So these persons should be kept away.
Yeah, safeguard. But with regard to the statistics that has been asked, I'm not sure whether there would be a statistical data with regard to the mortality rate of this particular group of patients. Won't be available, I think. No? Maybe, or is it?
Yeah, because I don't have a correct figures, but I've already shown with the age, especially different countries, the percentage will be different. But what we can say is, like, especially when these persons are infected, the mortality chance will be high, and a healthy young adult, when it is getting infected, it is very, very less.
So can we say 5 times more compared to a healthy adult with these people who are having the comorbidities? They will be having 5 times more.
I've already shown that it will be somewhere more like 8 to 10 times more, we can say.
Right. Yeah, there's another question from Dr. Dinesh Nambiar. He has asked, since the virus is detected only in the nasopharyngeal area, then what's the rationale of taking a throat swab? I thought he misinterpreted the word throat swab.
No. Please don't take it like that. What I had told is the viral concentration is highest in the nasopharyngeal area. That is why the throat swab was recommended to take from the nasopharyngeal than the oropharyngeal. But recently, even the CDC guidelines have changed. They are recommending both oropharyngeal and nasopharyngeal, because the patient is likely to cough and all when you go for a nasopharyngeal swab. But whenever possible, go with a nasopharyngeal swab. It doesn't, please don't take it like that. I didn't say that it is there only in the nasopharynx. What I was trying to communicate is there are many receptors in the nasopharynx, ACE2 receptors. So the viral concentration will be very, very high in the nasopharynx compared to the oropharynx. So even if you put some sterilizing solution to the oral cavity, you cannot completely remove the chance of spreading, because the nasopharynx cannot be covered with these solutions. Okay, that is what I was trying to convey.
Yeah, so can I add something there? Because it was said that compared to the SARS-CoV-1 virus, one of the challenging things was that the SARS-CoV viral load was not much there in the oropharynx, but here in the SARS-CoV-2, the viral load is much more in the upper respiratory tract and the oropharynx region, because then the transmission rate would be much more even in the symptomatic period. So that's a big challenge. Is it true the viral load is much more here compared to the CoV-1?
No, the main difference between SARS-CoV-1 and 2 is there was no pre-symptomatic phase in, pre-symptomatic spreading happening in SARS-CoV-1. Here you can see, I've shown you with the clear diagrams, the spread is happening in pre-symptomatic person.
What could be the reason for that? Yeah,
that we may not be able to say. That there are many factors between a host and viral interactions. So there may be many factors in that. So that is the main challenge with the present SARS-CoV-2. Because you may not be know who are there in the pre-symptomatic or an asymptomatic phase. So even a person coming to your clinic, he can become positive after 3 days. You may not be knowing that. The same way those are attending this program, many of us may be positive at this point. We may not be knowing that. That is the main issue.
Yeah, okay, thanks. So then Dr. Sunil has asked, I didn't get it properly. Environmental transmission is mentioned here as 10%. So in practice, please highlight the possibilities in dental clinics.
So first, regarding when you put it into the practice, first of all, one thing you have to, why I put it like that is, these environmental transmission, like touching somewhere, touching again, that is very minimal. The main transmission is through the symptomatic and pre-symptomatic phase. That is the main message you have to take. Then frequently touched space should be cleaned with a like a chlorine solution. The preparation is very beautifully given in your document, so you can follow that. But all the frequently touched area should be cleaned in a regular intervals.
That's clear. Then is there a possibility for environmental transmission to be increased after the lockdown days?
Again, I've already told, this lockdown extending is not practically possible for a country like India. If you are going with the lockdown, you may have to go with the studies from Imperial College or other disaster management group and all. You will have to go with a lockdown of up to 12 months or even more. Okay, Imperial College, they say it is projected up to 18 months. So that is not possible. So what we can do is practice all these precaution measures, then keep this social distancing very strictly. So that is the only practical way. Obviously, there may be some chance of spread, but we will have to take that risk and proceed.
Yeah, the question is, how is the pulse oximeter helpful in detecting asymptomatic COVID patients? As there was an article related to that. Whether it's practically
Again,
intended.
that is also misinterpreted. The pulse
Right.
oximeter is a very, very important tool, because we have extensively recommended that equipment to use everywhere. But what you have to understand is the hypoxemia will be seen in mildly symptomatic patients only, like those patients with a mild fever or like a minimal cough. They may be absolutely normal, but if you put a pulse oximeter, your saturation level will be low. So if you are already exposed to a patient and if you have a mild symptoms, then you can put a pulse oximeter and see what is the saturation. Then you can decide that. But for all asymptomatic patient, you put a pulse oximeter and see the saturation is normal. I don't think that will be a practical approach.
Yeah, but then the article says that even with the oxygen levels with a 70% or something, those patients are coming. Is it possible that a patient with a 70% oxygen concentration
That is why
oriented?
that is the main the feature of this patient. It is not that you should not interpret in a different way. If a saturation with a 70% can walk in the community, no. Like even if saturation is low, they can tolerate that. So the hypoxemia, these group of patients will tolerate. So they may be coming to an emergency department with a fever and cough. Usually a patient, when the saturation drops somewhere around 80%, they will be extremely symptomatic. But these patients will tolerate that. That doesn't mean that they will be absolutely normal. No, it is not like that.
So it doesn't apply to the particularly absolutely asymptomatic patients. It never applies. Yeah.
Yeah, exactly.
Okay then. Yeah. What about taking the next question is, what about taking hydroxychloroquine?
I've already mentioned that.
Mentioned. Yeah. Okay. Then should we, as dentists, be tested? Is there any test to determine the immunity? How are we supposed to get tested?
No, the only thing what we can do is, if you do a CAR test or an antibody test, and if you are tested positive with an
Is it available right now?
No, that is not available, because right now, Srijitra and Rajiv Gandhi Institute, they have already developed the kit, but both are under validation. I think within few days that will be available in Kerala. But even if you test, like if you are tested positive for IgG, that means you might have had a previous infection and you are likely to immune. But even WHO has clearly mentioned that, like previously, these people were given something like an immunity passport, and they were likely recommended to go out and interact with the people because they are immune. But now, with the available evidence, even those getting tested positive with IgG, you cannot say that they will be completely immune to these infections. So that is not a assurance that you will not get infected. Obviously, the chances will be less.
Then why is the mortality and morbidity rate so low in Kerala if you compare it with the developed countries? So there are many conspiracy or many things being spread, like the strains we find here are much low in virulence compared to that of.
There are many studies conducted in India, especially NIMHANS, the director of NIMHANS Virology Institute. Dr. Ravi was there in our platform few days back. So the strains, whatever we isolated, is similar to the Wuhan strain. There is no much strain variation at this point. There are some articles published, but again without any strong scientific backup or not peer-reviewed articles. So the strain difference is not true. My assumptions are, I may be wrong. As I've already mentioned, we were picking up these cases very early from the community. All the cases were picked up from the quarantine group itself. Like as you are mentioning, none of these patients were hypoxemic patients. Even those who are developing an oxygen drop, we were detecting very, very early. So those were given supplemental oxygen, other supportive treatment, or even the experimental therapies were instituted very early. So the progression to the very sick group was prevented by early implementation of these strategies. That is the only reason what we can say, the reason for reduced mortality in Kerala. There are other assumptions also which I don't believe that is true. One assumption is like the previous coronavirus, MERS. So there are many persons working in Middle East in Kerala and India as well. So we don't know whether the more people were infected with MERS. But again, that is also not a good concept to believe. Other theories like there are maybe many persons infected with the other coronaviruses which I was shown, the common cold and all. So they may be having some immunity. But these are all
the
proposed
BCG
arguments.
Is also there, no?
Sorry?
The BCG thing is also
been... Again, there is no point to believe that, because that is a vaccine against bacteria. That is unlikely to act against a virus. It's very, again, just an argument's sake, we can say that's all.
Yes. So it's all upon the effort of the Kerala Health Administration. So hats off to the team, especially including you. We could say that it's the reason why. Then there's another question. What about the salivary glands effect and the colonization of this virus in the human salivary glands?
I've not gone through any documents about that. Obviously, I will have to refer more and say, because I don't know like the ACE2 receptor, the predominance or the concentration in salivary glands. I'm not aware about that.
Yeah. Then the HCQ we have already mentioned. Yeah. What's a maximum temperature in which the virus can survive? Is there any study?
That is again like when the temperature is high, the virus the survival will be minimized. But the problem is, you can see even Maharashtra is very hot now, but there is having a huge spread, because the spread is mainly happening in the closed spaces. So the temperature is going to affect you in the open spaces. So if I am coughing out in an open space, maybe because of the temperature, the particle which is getting suspended, the lifespan of such viral particles may be less. But the spread is happening mainly in the closed areas. It is not happening in the open spaces. So the temperature is unlikely to be a major factor, but may be having a minimal contribution.
So that's with regard to the questions in the chat box. We have 30 or around questions in the question that we'll take after the inputs from the panelists also. So once again, thank you very much, sir, for the presentation, because it was a beautiful presentation, engaging and enlightening. And one of the primary intentions of IDEA Kerala State to organize such a webinar was to provide the right kind of information, because as we know, we are access to a lot of information today, but most of that we get to access is wrong information or false information. So, and at least when it comes to health related information, as health professionals, we owe a duty to our society and to ourselves that we need to have the right kind of information. So from the right people also. So we have to verify the source also. So we have the right person here, ladies and gentlemen, the right with the right credentials, because as far as epidemics or infectious diseases is concerned, Dr. Anoop Kumar, I think that he is a go-to person in this part of the country. So thank you very much, sir. And now we'll go to the panelists. We have the esteemed panel of experts. We have the Dr. Ramanohar, sir, the former principal of Government Dental College, Calicut. We have Dr. Shaji Joseph, President, Kerala Dental Council, and we have the Dean of KUHAS, Faculty of Dental Sciences, Dr. Anil Kumar. We'll go, I think, in an alphabetical order. We'll start with Dr. Anil Kumar. Can you please share your inputs, Doctor, with regard to this presentation, and also your take on this infection with regard to dental practice in general?
Thank you, Dr. Anoop, for that excellent and elaborate presentation. You have actually touched upon almost all the areas in detail, especially regarding tests and infectivity, masking procedure, everything, almost everything you have touched. Now, regarding the masking, I have just some questions that I would like to ask. Usually, you have already told that if it's a aerosol generating procedure, invariably, we have to go in for an N95 mask.
Yes.
Can we say like that? Okay.
Yeah, yes.
Yeah. All other procedures, we can go ahead with surgical mask.
Yeah.
Surgical mask means usually we get in 2-ply, 3-ply, that's what. We have got a confusion regarding that.
Ideally, you have to go with a 3-layer mask, but even in all the hospitals now, getting a 3-layer mask is very difficult. So in that situation, I think we can compromise for a 2-layer mask at present situation.
So it can be either a 3-layer or 2-layer. Okay. And then face shields along with that.
Again, only for aerosol generating procedures. Otherwise, you don't need a face shield.
Okay. What about goggles?
The same thing, sir. It is
Same.
the same thing only. Yeah.
Okay.
Goggles and face shield recommendation is same.
Okay. Then another normal, as a prosthodonticist, I have got some doubts regarding these impressions. We make the impressions of the dentition. That is just, once we take the impression, normally it will be filled with saliva. We just wash it under the water and we are supposed to disinfect that. Don't you think in this scenario it will be most important that we ensure that it is disinfected with the proper disinfection?
Yeah, obviously. That is the point I highlighted with that diluted alcohol specimen. So this virus being a capsulated virus, like even though we recommend more than 80% alcohol, even a 40% alcohol, or even a small like a soap solution or any other alkali or like an acid solution, these all can kill these viruses. So you don't have to go for an ideal disinfectant and all. Any soap or like an acid containing or like an alcohol containing solution can disinfect these things. But as you have correctly mentioned, anything like touching these oral secretions should be disinfected. Obviously, no doubt about that.
So usually we use 2% glutaraldehyde. That's what is recommended, because
and I think
the material aspect is also there.
Your document has already, I think, Dinesh can
that is given there. Right.
Glutaraldehyde actually is a high-level disinfectant, but what Dr. Anoop Kumar now is saying that even a mild disinfectant can do the job.
Yeah, I agree. But if you are doing a alginate impressions, you cannot normally immerse it in that alginate impressions. So we'll have to go in for some spray sort of
sprays, right? Exactly.
In that case, we'll have to go for glutaraldehyde. And the cast also, dental cast also is another. We make the cast, then we send it directly to the laboratory. We might need to disinfect that also. That is one part. Then another usual doubt is that we normally use the compressors. So compressor has got an inlet through which the air is sucked in. Some of the clinics, they keep these compressors within the clinic itself, so that where the patient is being seated, adjacent to that itself, there will be the compressor. So don't you think that these aerosols that is already generated from these procedures can be sucked back into the compressor, which is, there is a tank in the compressor and the air comes back through to the next patient for another procedure through this. So that is, couldn't that affect the cross-contamination?
But then that's why we suggest there should be an anti-reflex or anti-retractive valve in the handpiece.
I agree. That is through the handpiece that what we are seeing. Right. What I say is that there is an inlet for the compressor. Air is being sucked in, for getting it compressed in that tank. Right, so that air from the clinic only, it is going, as what he has already told in the air conditioners.
Yeah, the contaminated air will be getting filled in the compressor.
So it is always ideal, I think, to keep the compressors in a different room where we are not actually treating the patient. That is one advice that I would like to give. So these were some of the things. Thank you very much. That was a great, wonderful presentation.
Yes, thank you. Thank you very much, Dr. Anoop Kumar. And now we'll move to Dr. Ramanohar, sir. Can we have your input, sir?
So you will have to unmute yourself, sir.
Yeah.
Ramanohar, sir?
Can you hear?
Yes, sir.
Yeah, see, it was a real lucid and informative talk, no doubt about that. I have only a small question. What about this hypochlorous acid? It has been coming in, I mean, we've been hearing about it for the last about a couple of weeks. hypochlorous acid supposed to be extremely useful
as a disinfectant,
yeah, as a disinfectant. Any
and a
idea about
fumigant
that?
also, chemical fumigant.
Like again, sir, I'll have to recheck that because that is not an agent what we are regularly using in our practices. So I'll have to go back and check.
But it's been marketed now in dentistry especially because it is considered as the most potent in the chlorine family that's being considered
And
now.
least
Any chlorine containing solution, like if it is having something like a free radical, all those things, that should be effective. But I have not gone through that particular chemical and its efficacy.
it's supposed to be very non-irritant and does not damage any of the equipment in the clinic.
Non-corrosive, totally,
So what we can understand is like this virus being a capsulated one, as I've already told, anything which can break this capsule can be a disinfectant for this virus. So disinfecting this is very, very easy here.
Yes, the point taken. Yeah.
Can I ask one more?
Yes, sir, please.
Sure, yeah, you can.
Now, see about the vaccines. Suppose they do come up with a vaccine in the near future. Is it possible that these viruses might mutate and then these vaccines will become ineffective in next year? Is that a possible
point? Because this is a novel coronavirus, we don't have any evidence as on today that this virus is getting mutated. But it is too early to say that this virus will not get mutated. It is likely that the virus can get mutated. So we will have to wait and see for the results to come. As on today, there is no evidence. It can change in the next week.
Is that information right that this already has mutated to around 30 strains or something?
That is a fake information. There is no such information so far. Like even the genetic sequencing done in India is much similar to the Wuhan strain.
Oh yeah.
Thank you very much, Doctor.
Yeah, thank you, Ramana sir. Now we'll move to Dr. Shaji Joseph, the President of the Kerala Dental Council. Can we have your input, sir?
Dr. Shaji, I'm Dr. Deepu here. Dr. Shaji, he heard almost last 5 minutes, he couldn't hear, the connection went off. And so he called me just now and told me to congratulate Dr. Anoop on a very excellent presentation. And he has asked me to personally convey his thanks for throwing so much light on this. And sorry that he couldn't stay back for the question and answer. So on behalf of Dr. Shaji, the President of Dental Council, I wish to thank Dr. Anoop for this presentation. And I have one doubt personally. What about sodium hypochlorite as a disinfectant? What is your take, sir, on that?
That's already mentioned, I think,
Okay. Same.
Yeah.
It's pretty effective, right?
Yeah, any chlorine derivative which has its oxidative properties should work,
But what we have to understand is, again, there are many, even many authorities have come up with sterilizing the persons. Like you might have even seen in newspapers and media, like they are making some tunnels and something and disinfecting the people. So that is actually a foolish concept. That is what I wanted to convey.
No, but as surface disinfectants, it's good, right?
The surface disinfectant is useful only in the frequently touched areas. And obviously, we like disinfecting your instruments also. Initially, you can clean with that, and then you can use with their normal procedures. But because the normal procedures will have to be carried out, because you cannot think about only this virus. There are many other things which we were worried about before. So you have to disinfect with this time, and again you can go with.
That's part of the standard precautions, right?
Standard precautions, exactly.
Yeah, exactly. Yeah. Okay. Now we have plenty of questions in the question and answer box. Like I think our panelists can also chip in with their suggestions with regard to the answers to this question. The first one is from Dr. Aparna. She is asking, is there a viral load in the saliva? If so, can we quantify it with relate to other nasopharyngeal secretions?
Yeah, it was done. I've already shown that slide also. Different secretions, like the maximum concentration is seen in the bronchoalveolar lavage fluid, followed by sputum. Then we have nasopharyngeal secretions, oropharyngeal secretions, then only the other secretions. That was quantified. I have you can my presentation will be available in the YouTube channel, so you can go back and see that slide. I've already mentioned that.
Slide regarding that. Okay, right. Yeah. Okay, then the next is, will the virus be, there's an anonymous attendee, will the virus be killed when it enters the stomach or the GIT? Is that the reason why the government is advising the public to drink water more often?
No. By drinking more water, you cannot kill the virus. Drinking not more water, adequate quantity of water in this situation definitely will prevent dehydration and will keep you healthy. It is nothing directly related to the prevention. The same way, so many vitamins, minerals, foodstuffs, all those things being recommended, but there is no scientific data that having a particular vitamin, mineral, or a particular food material can reduce the chance of infectivity or can like provide you some immunity to keep away from this disease. Nothing like that.
Yeah, the first part of the question was when you asked that will the virus be destroyed while it enters the GIT.
Again, I've already told you, the receptors are there both in respiratory tract, GI tract, and again some part of conjunctiva. So these all areas can act as a source of entry. So even if it is deactivated down with a gastric acid, before that it can get adhered to the receptor and can enter in the body surface. So it is immaterial whether it is getting deactivated in the stomach. Before that itself, that can be used as a portal of entry. Any contraindication to the analgesic in a COVID patient? Yes, but in dental practice at present you can continue with the same recommendations what you are following before. Infrared thermometers are useful to detect temperature because you are not touching, and the same can be used again. No harm in buying an infrared thermometer, but I don't know how practical that will be in a clinic to screen everyone with a thermal scanner and do that. That I think your panel will have to give me an answer for that. Dinesh sir or I think Anoop Kumar sir or Ram Manohar sir can.
I have a thermal scanner which I bought about a year back, and it is working fine. But now the cost has gone up by about 4 times.
Yeah. What price did you get it, sir?
What is it?
What price did you buy it?
1,300 something from Amazon. Yeah.
Amazon,
And it works fine.
Oh, yeah.
Because I checked everything. I did not buy it for checking patients. I bought it for checking the temperature of the ceiling in different places.
So, other question is is it safe for a person with bronchitis to do a volunteer service? No, that is the one message you should all understand. Even any of us being an healthcare professional, showing symptoms like influenza-like symptoms, any fever, cough, respiratory symptoms, you should keep away from the public and the family members. There is no doubt about that. There is no volunteership, not even going to the professional areas or to the public place. You forget about the voluntary this thing. That is the only way by which we can prevent this disease and prevent the spread. That should be there in our culture. And again, coming to the culture again, washing the hands before entering the home. Like in Malayalam, we used to say always, നമ്മുടെ നാട്ടിലൊക്കെ ഇങ്ങനെ കിണ്ടിയിൽ പണ്ട് വീട്ടിൽ വെള്ളം വെച്ച് കഴുകുന്ന ആ ഒരു ശീലം. We will have to keep some tap in front of your house, and before entering the home, you should wash your hand. And again, you should minimize the things what you are carrying from your clinic or from the hospital also.
What can I ask one question? Sorry to interrupt.
Actually, there is a question for Anoop Kumar also here
in
the chat. Yeah, that's regarding the efficacy of sodium hypochlorite in disinfecting impressions.
Yeah, it is considered effective. We can use that. It is a second line after glutaralide. We can think about sodium hypochlorite also. One person.
Yeah, sprays can be used.
Yeah. The studies are there. It is okay. One question that I would like to ask to Anoop sir is that you are told that the rapid kits will be available soon. Can we, in some manner, utilize these kits for selecting our patients?
In dental clinic?
Yeah, in dental.
No, never. Because I've already told, no, we can have only if he's having an IgG positivity alone. Okay. Even in that case also, it can be in a window period. I've told you, no. So that way, these rapid kits are basically for community surveillance to see how many persons in the community is being infected. As a diagnostic test, you cannot use these antibody kits, even though it is described.
Rapid tests are never conclusive in nature, so that's the.
Can I ask a question, please?
Yeah, please, sir.
Well, my question is: most of these viral fevers, viral infections have deranged the blood pictures. So, in this virus also, there have been reports of petechia, and splinter hemorrhages and all that. So, is there any reports of blood parameters being deranged?
Manifestations in the skin manifestations?
Yes, sir. The main parameters described and across the cohort is lymphopenia. The low count with a low lymphocyte count is being observed in major groups. But as you have already mentioned, the mild thrombocytopenia, elevation in liver enzymes, then again elevation in LDH, different patterns have been observed. By looking at a single pattern, you may not be able to make any diagnosis. Same way, clinical features also.
I am worried about the fact that any derangement can cause the problems after dental extractions or procedures.
No, very, very unlikely. The incidence of thrombocytopenia, even though it is reported, that is very, very minimal. And again, that will be observed only in symptomatic patients. You may not observe such changes in an asymptomatic patient or in a patient who is already being recovered.
Can I ask a question? Yes. There is a government app called Arogya Setu, I think.
Yes, sir.
The thing is, is it possible for them to let the dentist use it to know whether the patient that is in front of them have a
positive contact? Yeah.
That is actually, I will have to say some. I don't know whether it is a political this thing, but that is a major mistake the Kerala did, I say, because I was also following it up what is the IT mission was doing in Kerala. So that is exactly what you are mentioning. So as per the IT mission's the plan, whatever may be the source they were using, any person who is returning should have a mobile and his mobile will be tracked. So then everyone will be having an app. So the moment that person is coming to you, you will get an alert that the person near you will be is already having a contact or person is under quarantine. Or if he is moving away from that so-called geofencing, you will get an alert that that person will get an alert, and the police station or the control center near also will get an alert that this person is going away from that. So that opportunity we really lost because of unnecessarily political discussions without knowing the importance of having a technology driven quarantine and isolation, I say. I don't know whether the method they utilize is correct or it was any problem in implementing that. I am not an expert in those fields, but it is obvious that we should have such the way you beautifully mentioned, such electronic applications to see what is happening. The problem with Arogya Setu is only person who are entering into the Arogya Setu data they will be having. It is nobody's
the Bluetooth should be on also.
Yeah, you can very well go out of that. It's voluntarily you are giving. If you are not sharing your data voluntarily, nobody will be knowing that. You don't have to worry about data sharing in such a crisis situation, because this data should be known to others. Then only we will be able to take precautions. As a dental surgeon or a healthcare worker, it is very easy, because one patient, if is coming to my hospital for a delivery, I may not be knowing that whether that patient is in quarantine or not. There is no way. Only thing they have to self-reveal. They are not self-revealing. We will have to take that risk.
True. Actually, we know the countries where they have these privacy laws and all these liberty kind of things, they are faring very badly.
That is applicable in privacy, yeah, especially in a disaster situation. I don't think there is any role for such so-called privacy. Or what privacy we are giving? Only that we have symptoms or this is our address. I don't think that privacy, even if you log into your Gmail or WhatsApp, you are giving that information to the whole world. Even today, when I was looking some train ticket, the moment I am next moment I am getting message in my WhatsApp and email that the hotel, the rooms available there, the food available there. So that is the present data safety what we are having. So anyway, really sorry for dragging the discussion out of this scientific matter.
It's fine, sir. It's very much engaging. Now, another question is, I think the panelists can be in a position to answer this. In one of the webinar by Dr. Gopi Krishna, he said that using rubber dam in an aerosol procedure would be effective. How effective is it by Dr. Binathan? Okay, advisory, we know that rubber dam can. Dr. Ramanohar, can you answer that?
I think rubber dam should be used, especially for treatment procedures where it can be applied. It should be used. But most of us, including me, are not very adept at doing it. So we had to learn it. I think it's the right time to learn.
Yes, exactly. That would be a positive change that COVID this would be bringing to dental practice, I would say. Yeah, the more use of rubber dams. So for the posterior cutting and all crown cutting also, you can suggest. What do you say?
Posterior crown cutting, it will be very difficult, but definitely
you will have to expose a couple of teeth.
Yeah, right. Yes. Okay. Then the Dr. Sabu Kurian, past president, those who missed some parts of the presentation, will this webinar be available in the net? Yeah, definitely it will be. Now say once again, Dr. Anoop Kumar sir, once again about the repeated use of N95 masks, sir.
Yeah, it's very simple. You buy 4 masks, then you buy the Ziploc plastic cover also. So today you use one N95 mask. So and again while using, you should never touch the mask again. So after that, you just take out the mask and keep it in the Ziploc cover in your clinic itself. The second day use the second one, third day use third one, fourth day use the fourth one. The fifth day you again start using the first one. So the whole month you can use the 4 mask. That is enough. Even in ICUs we are practicing that, and even in the US the the intensivists, those who are practicing in the ICU, they are using that. So I think that has to be practiced, especially when there is a huge shortage of N95 masks. But if it is soiled, no, you should not reuse that. If it is not soiled, yes, surely.
So ideally, they are suggesting to wear a surgical mask over the N95 if we are using it.
No. Again, I think contamination
to prevent it, to prevent it from getting soiled frequently.
It is not necessary. It's unlikely that it is getting soil. No, it is not. Direct spillage of secretions are very.
But in our situation, this aerosol production will be more, no, sir. Normally, from the mouth, is when we are using the.
The soiling doesn't mean that aerosol generations are like a blood or spillage or some direct spillage over to the mask. That only you can take it as a soiling.
Okay.
Next question is regarding the intermittent spraying of hypochlorite is advised if it's effective. What about the irritation it can cause to the health worker and also to the next patient that we have described in our guidelines actually? And what will be the ratio of hypochlorite? I think he means the concentration of hypochlorite to be used. That's 1% sodium hypochlorite to be used. It doesn't cause much irritation. That's something we have mentioned in our guidelines. Now, next one also, can you please elaborate on the protocol for handpiece sterilization? Again, we have mentioned all those things in the hyperlink has also been given regarding sterilization in detail. So those are the questions in the chat box. And coming to there are questions in the, when Dr. Mahesh Raj is asking if there is a scarcity of N95, is it indicated that we can wear 2 surgical masks instead of 1 N95? Will that suffice? That's what's asking if there is a scarcity of N95. Anoop, sir?
No, it is basically because of the seal you are producing. You cannot have a seal with 2 normal.
Similar seal with a surgical mask. Okay. How many days after can a COVID positive patient undergo a normal dental procedure, routine dental procedure? How many days after?
No, usually we ask them to continue in self-isolation for 14 days after discharge. Only 14 days after discharge they can be taken for any routine procedures.
14 days. Can air conditioners be used in the reception area?
Everywhere it is applicable. It's advisable to have a open space everywhere. But some areas you cannot immediately change the AC, everything. In those areas, we will have to keep the social distancing, everything in a strict manner. You should not allow more persons inside the room. Those things can be taken care. You cannot take out the AC from everywhere. It is impossible.
And 14 days, this we have discussed, I think. 14 days, is it enough quarantine? Heard that few people from abroad, after quarantine for 14 days, after 30 days even, they are showing positive.
That I have clearly mentioned. That is only PCR positivity.
Right.
We are discussing about reducing the quarantine time to 10 days rather than keeping at 14 days.
That was the CDC guideline also, right?
Yeah. They're also planning for the same thing.
Things also have been answered. What about using infrared thermometer and pulse oximeter for screening?
We have already discussed all those things.
How effective is that's again related to dentistry in particular? How effective is an extra oral suction good? So can you answer, anyone from our panel? Extra oral suction, is it good to control aerosol production? There are many things in the market.
Yeah, we are not sure about no studies as of regarding that, but some suction like that might be effective if you think logically.
Better than nothing.
Better than nothing. That's it.
But then it's exorbitantly costly, the things that they're marketing now. Yeah, that's not.
But you need high volume evacuator.
Yeah, right. Yeah. Yes.
That I don't
Any
think.
comment? Preparation bronchitis. Okay, these things are answered. What about using? Oh, yeah. What's the effect?
There are 3 persons, Dr. Sarida Sajeev, Krishnamurthy, Havildar, and Girish Kumar. They have raised the hand. Can we take the question?
Okay, right. Yeah.
Yeah, Dr. Sarida, you can talk now.
Yeah.
Please unmute, ma'am, and talk.
Dr.
You will have to
Sarida,
unmute,
can you
ma'am.
ask?
Dr. Girish also can talk now. You will have to unmute and talk. Dr. Girish, or by mistake you raise the hand. And Dr. Suraj SS also you can talk. Dr. Suraj? Yeah, please.
Yeah, Dr. Suraj. The question that I want to ask you is, there have been some information, primarily from WhatsApp sources, so I don't know the veracity of it. The question is that the essential pathology of COVID-19 is because of intravascular thrombosis rather than the sort of viral pneumonia, as we understand it, bilateral viral pneumonia. And the mainstay of treatment is anti-inflammatory and not, and ventilation has very limited role, if any. What's your take on that?
Anticoagulant.
Yeah, that is actually a very brilliant question. Dr. Suraj has gone extensively into the literature, I understand. So this question is having different parts. One thing, the cause of hypoxia, that is reduced level of oxygen. The main cause is because of pneumonia and the damage occurring to the like alveoli. There is no doubt about that. And whenever the patient is hypoxic, you cannot overcome that with oxygen supplementation. You will have to ventilate those patients. There is no doubt about that. Now coming to the microthrombi, that again, even the autopsy studies are showing that even there can be minor thrombi formation in these pulmonary vessels, and that may be aggravating the hypoxemia. And now the people are advocating the thromboprophylaxis and even anticoagulation for such patients. And coming to the last theory, that is, it is basically the hemoglobin damage that is producing the decreased oxygen level. So I was just trying to understand about that theory. So that was actually a theory produced by some Chinese students, engineering students, second-year engineering students, without any medical background, using some mathematical modeling and postulations. So that assumption is completely wrong, because when you have a hemoglobin damage because of these heme toxicity or the virus directly eating the heme, you will be having a dip in SpO2 value, but your PaO2, that is arterial oxygen, should be normal. But here we have both arterial oxygen is low and again your SpO2 is low. So that is nothing to do with the heme damage. But as you have correctly mentioned, it is because of the microthrombi formation and again because of the alveolar damage. Thank you so much for that brilliant question, Dr. Suraj.
Thank you. Thank you.
Yeah,
one more question, if I ask, is there any role for defogging or fumigation in between patients in dental clinics?
Again, that is not practical, I feel. Like you need some contact time for all these fumigation. You need a closed space. The fumigation recommended is with hydrogen peroxide, all those things. So even in ICUs, practicing the fumigation is a bit difficult. So what we can do is having a proper ventilation or having an air exchanger or an exhaust fan, as I've already mentioned. I think that will be ideal than having a going for fumigation after every patient. That will be very expensive as well. I don't think that is practical, but I think the experts on the panel can answer that.
You take on that, sir?
Yeah, please.
Ramana, sir, I think the practical thing would be at the end of the session or something. Yeah. Okay, carry on, sir.
I don't think it's a really practical thing, especially the time involved and the number of patients that you can probably see will be drastically reduced. And then I don't understand the efficacy of fumigating the streets and things like that.
No, that is actually already been told, sir. Like you can even see the videos where the vehicles are sterilized. Some antiseptic sprays are
waste.
That are not just eyewash only, sir. Nothing. It is not going to work at all. Maybe a public transport frequently touched areas you can screen. You can clean. There is no recommendation by any bodies, because that is what I was searching, because even in the initial videos, China and like other Korea and all was showing so many street fumigation techniques. So even when the disease started hitting us, I was trying to get the reference for that. There is no reference, no recommendation. That is not a scientific method at all.
Yeah, then there's a question like, is there any specific oral manifestations in COVID positive patients? Some oral manifestation that's definitive in nature. Are there any manifestation like that?
There is like something like anosmia has been described, but any specific oral lesions or manifestations, I've not seen any paper describing like that.
Yeah. Then to the speaker, can you make an opinion on what is going to be the scene 1 month later or in the recent future?
I've already answered for that. It will be going to maybe in terms of number of patients will be increasing. You cannot have a complete eradication in this disease. We will have to get adjusted to the virus. That is the only possible thing going to happen.
There's again a question on the policy matters, like Dr. Vinci Anthony has asked, wasn't reverse quarantining better than a total lockdown or shielding the people?
We should have the reverse, total shutdown at that point was really effective. That is what we have observed in Kerala and even in India. Even though the number of cases has gone up, even now the doubling time in India is somewhere around 10 days. So that was possible only because of complete shutdown. But now we cannot continue with the shutdown for prolonged days. That is why we should try to shield these susceptible persons from getting infected.
Now, Dr. Subodh has asked that how can we know, is there a chance to know whether this patient is an asymptomatic carrier? I think it's visual thinking.
That is the main problem with this COVID-19, and that is what I'm saying. Preventing community spread and again completely eradicating this virus is impossible because the same reason what you told. You cannot do anything on that. You cannot do the complete testing of the community. The whole persons in India testing at the same time is impossible. It is not practical. So this will continue like this.
He has also asked, is there any relevance with oxygen? That maybe he is referring to that pulse oximeter thing. Is there any relevance with oxygen
that
saturation?
We have already discussed now, sir.
Right, yeah. But then another question from the same person: can a COVID-treated and cured patient can be a viral carrier of this infection?
No, never. This carrier term is mistakenly used. It is only the pre-symptomatic and asymptomatic persons with a short duration of viremia. You cannot, in fact, call them as carriers. They are only viremic persons. It is not carrier stage. Carrier stage is something what you can see in the typhoid and all, where the patient can continue to shed the virus for a long time. It has been described in polio also, where the virus can be shed for a long time, but not in this COVID-19.
Yeah, thank you. So then Dr. Nisha Saumitran has asked, that has been answered, I think. How do we sterilize the N95 mask after the 4th day? Yeah. Then being an asthmatic myself, is there any extra precaution I need to take while working? That's what she asked.
No, I don't think like the whatever inhalers you are taking, there is a clear-cut recommendation by the American and British thoracic societies on that. If you are on an inhaler, you have to continue that inhaler. But if you are really on very high doses of inhaler and all, if getting infected, there may be a slight increased risk, but that is also being debated. There are some information coming now saying that the patients on inhalers may be having a protective role, but again, all these WhatsApp information not a reliable source at all. We don't have any data like as on today. What with confidence we can say is, if you are on medication, that has to be continued. It should not be stopped.
Yeah, can I ask something? Because being a female, does she have more resistance? That's what the statistics say, or something like that.
No, even when the Kerala data, when we were analyzing, the person who got infected, I was showing the data, no, from 360 something, another 145 got infected. So in that 145, there was actually female predominance. So the female predominance may be the close contact of the returned persons, because the returned persons had a male predominance. So the close contact of those persons may be females. That is why they got infected. But what is observed is, even though they can get infected, just like the age-wise distribution, the severity-wise distribution or the mortality is slightly less in female group. But again, we will have to analyze the data in detail, which age group of females were infected and again, many comorbidities of incidence of comorbidities. So without analyzing the data in detail, we cannot say that the females are having a protective effect.
Okay, then the third question from her is the speculation regarding the approximate time when this panic is going to end, the pandemic.
Told.
Yeah.
Can't answer that.
Practice can be good regarding HCQ that answered.
That also we have already told.
Yeah.
There is another question from Dr. Lalu on biomedical waste in dental clinic. I think that we can only answer that. Biomedical question is, sir, can you add a little bit about special precautions in handling biomedical waste in a dental clinic? Can you answer, sir? Dinesh sir or
no, I didn't see that question. Like the biomedical,
yeah, I think some of the panelists can take that question. It is a bit down.
The biomedical protocol we have, the everything we are now, the segregation is done at the source. We have all sorts of information. We are doing it. The details are in the guidelines also. The image is handling that. We have to follow all those BMW recommendations that has been notified by the government as per the norms. Then extra precautions with regard to COVID positive or something like that. That's what he means.
Must be about the PPE, how to dispose.
How to dispose the PPE.
Yeah,
I think there is a separate protocol for that. Yeah. Okay. We'll come to that one by one. Dr. Sarita was asking, can we use a normal mercury thermometer like a digital thermometer, disinfect it and use instead of a non-contact thermometer? Can we use a normal thermometer and disinfect it later? That would be very.
So that is not recommended, sir, now, because it's again you are like manipulating the secretions. You are not recommended to use a normal thermometer now.
Yeah. Yes.
Can I ask a question?
Yeah, please.
How about these air purifiers with the HEPA filters, especially in confined clinics with very little, very few windows and things like that?
HEPA filter is very expensive, sir. Even in the hospitals, like in the operation rooms, it is difficult to afford, because depending on the area, the air exchange, everything, you will have to practice an HEPA filter.
No, there are.
People who can afford it can, yeah.
There are standalone HEPA. I mean, nearly 300 cubic meter air displacement ones are available for around 20, 27 and all that.
So, sir, ideally, the HEPA filter basically, when you are taking air inside, these HEPA filters are used. Okay, when this air is being pushed out, as I was told, this virus cannot travel quite long. So even if you push out using these air exchange fans, that is not going to spread the disease. So a normal air exchange fan will be a cost-effective thing, or even a normal exhaust fan in a clinic will be an effective way of reducing the aerosols inside the clinic if it is a closed space.
An anonymous person has asked that heard that Italy has come out with a vaccine. Is that news true?
So there are every day the news are coming, but the only thing what I know is the Oxford University in UK, they have like almost formulated a vaccine, and as they cannot do a massive production, they have contacted the Serum Institute of India, and we are going to make the massive production for that vaccine. But how effective that vaccine will be, and even if we are producing with their technology, how much vaccine can be used in our country, those things are not very clear. Again, we will have to see further data on that. But one thing what we can say, in 2020, I don't think we can expect a vaccine. Maybe by middle of 2021 or like early 2021. Depends.
But then, even when a vaccine comes in a country like India with 130 crore people, to get all the people inoculated, it's a humongous task. Right?
The only advantage, like the healthcare workers can be protected, like the influenza vaccine. Right. Like in all the persons working in the ICU, we are all vaccinated for influenza. Same way, like all the IDA members or dental surgeons or all other doctors can be vaccinated.
People,
whole community, I don't think, as you have already mentioned.
And then those who are under aspirin, perhaps for some cardiac-related problems, those who are under aspirin, is there a more likelihood of them getting infected?
No, it is not like that. If you are getting infected with a cardiac, the person with a cardiac disease, or like the age more than 65, the chances of producing acute coronary events in such persons are high. It is not that because of aspirin there will be increased risk. It is possible, like as we have already discussed, the person for taking a non-steroidal anti-inflammatory drug like an ibuprofen or your diclofenac, after you are getting infected, the chances of complications will be more. You have to continue all the other drugs as you were on.
Then can our PPE, I think he's mentioning about the gown that we are using, can it be reused after applying some sort of surface disinfectants?
No, surface disinfectant is not possible, but reuse of PPE has been also like tried, but you need all plasma sterilizers, all those things. Again, practically not possible, I feel. So as I've already mentioned, the practical thing possible will be to use a disposable surgical gowns in your clinic, and obviously you will have to escalate the the cost of procedures also based on that. I think the panelists will be a better persons on explaining that.
The washable thing, the reusing after disinfection, we also haven't recommended it in our guidelines. If we have to use a washable, yeah.
You'll have to have bins for all that. Then you'll have to have a separate washing machine. You can't wash it in your house washing machine.
Right. Yes.
Then
yeah.
you need a lot of space.
Right. Dr. Epen Thomas, who has been a resource person for our guidelines committee, has asked, like, will this virus spread through any cuts or wounds other than the T-zone? Is there any other portal of entry?
Usually now the entry like only the GI tract, the respiratory tract, and conjunctiva. These are the three entry areas described now. Because again, as I've told, this is a novel virus. We don't know exactly what is happening, but with the available evidence, I can say that.
Even through the eyes, is there any evidence that it can cause
conjunctiva?
Conjunctiva,
there is an evidence.
Conjunctivitis can be caused. Other than that, can a respiratory infection can be caused.
Yes. Conjunctivitis has also been described. Rather than conjunctivitis, the direct spread through the conjunctiva is also described.
Okay.
That is why you use eye shields.
So the problem, sir, the problem is when I use loops for magnifying. So if you want to protect your conjunctiva, you need to wear goggles, close fitting. Then you can't use the loops, and then you need the face shield also to prevent splatter. So it becomes very difficult. You can hardly see through all this. Your prescription glass, goggles, then your loops cannot be used. Then very difficult to work.
That is the issue what we are also facing in the ICU, sir. Like usually for doing the intubation, we use these like face shields. So now the available face shields, I don't think is of good quality. So the moment the light we put it in the laryngoscope, we will get a blurred vision. It will all start reflecting the lights. So your vision will get impaired. So that is a real issue.
Practical issues are there. The quality of work may be affected. Yeah, then that's the question, Dr. Lalu. Can you add a little bit of the special precautions in handling biomedical waste? So that was the exact question. So obviously we have suggested to the auxiliary staff, they should be wearing, especially the cleaning staff, the heavy duty gloves, they should be wearing N95 masks, and if possible, and protective eyewear. So they have to take care of these people who are handling the biomedical waste management. That again has been described in guidelines thing. Is it true that children with COVID-19 are reporting with Kawasaki disease?
There are some case reports. It's not that they are reporting with Kawasaki disease. Kawasaki-like illnesses have been reported from UK cohort. So like any children coming with the symptoms suggestive of Kawasaki, at this point, they should be screened for COVID-19.
This again has been discussed. What temperature is considered to be fatal for the virus that we have talked, I think. Any confirmed data the virus won't survive more than 4 days?
It's based on scientific data only. That is why I've told it is not the guideline produced by me. It is a guideline recommended by CDC and again NHS in UK and again the Infectious Disease Society in America. So it is extensively practiced across the world. That is based on the scientific evidences.
There has been some, that Dr. Suraj, that he already raised that question. the same procedure rotation. It's the same procedure for rotating the mask effective for gowns as well. That is a pretty contentious issue.
But gown being very like big, you cannot like anyway when you are removing, you will have to touch some part of that.
Right.
Mask, the advantage is like you can without touching that you can remove. A mask like removing without touching everywhere and keeping somewhere and use it again will be really difficult, I think. So in the
Can be applicable to the gowns.
I don't think that will be practical.
Right. Then is there any significance in not using air conditioners in dental clinic? Absolutely, yes, I think.
Yeah, if possible, that will be the best solution nowadays. Like if you are going to make a new clinic or something, or you can modify, switch off the AC, have a adequate ventilation. No doubt about that.
You said that we would have to get adjusted to the virus. What do you think we should do to get adjusted to this? I heard in some place that we have to try to increase our immunity. Is that what you meant?
You are from Kerala, so what you can do is today in News 24 channel, we are doing a program from 3:30 to 5:30. അതിജീവനം അല്ല വേണ്ടത് സഹജീവനമാണ് അതാണ് അതിന്റെ തീം that is with the IMA members and again like experts in this medical field. So please listen to that, and again you can hear from the views from different medical experts and like me alone explaining my view or imposing my view onto your brain.
The title is beautiful, sir. അതിജീവനമല്ല സഹജീവനമാണ് വേണ്ടത്. Yeah. And then, is there any chance, Dr. Faisal has asked, is there any chance to get infected again, even if you are cured of this COVID-19?
No, that is again, that also news was circulating that reinfection is happening. So for the reinfection, 3 theories were suggested. One was the reactivation of virus. There are many diseases where the virus reactivation can happen. The second possibility considered was the immune response may not be adequate. That is why there can be a reinfection. Sometimes I've already told some immune response may not be adequate. But the third, the postulate was gaining more acceptance and it was more scientific. As I've already told, this is basically because of the sampling errors. Like even if a same person, like even in Kerala, you might have heard that the morning tested positive, evening getting negative. So what was the medicine used to like make the patient negative within 24 hours? The discussions were going on even in that way. So what is happening is basically these PCR tests are very, very sensitive. So once specific, not sensitive, specific. So once you tested positive, it is likely that you are positive. But it is not, that means the test is very specific, but it's not very sensitive. As I've told, if the viral load is not correct, your sampling technique is not correct, it is possible that you can test negative at one point of time. But after a few more days, if you do a proper testing again, it may be showing positive. So it is basically a technical issue which has been misinterpreted as a reactivation. That is a common accepted statement in that regard.
It is during swab collection or something like that.
Yeah, maybe. Yeah,
now, in that context, can I add something like we heard recently that the people coming from Dubai, they were deemed fit there, totally negative, and immediately after reaching here, they have been
no. That is why I was clearly told what tests were they were undergoing was either they were like undergoing the thermal scanner where the temperature was tested, or in some countries only the antibody, the rapid card test was done. I've already told the initial phase your rapid card test will be negative, and later on when you develop symptoms you do a PCR test, you will become positive. That is why all the persons who are returning from Gulf, even if you are having a PCR negativity or an antibody negativity, you should be in quarantine for 14 days, and it is likely that you can develop a positivity at a later time. So having a negative report is not an assurance that you will not get infected in another 14 days.
Yeah. But one person is said to be actively symptomatic, then even then, the second person.
It is also possible that active symptoms like there were
fever would have been there, no, right?
Yeah, they were excluding the persons with active symptoms. That is very, very unlikely.
Yeah. Okay. Then I think it is an important suggestion. Like if the government can inform the profile details of these patients and the quarantine to the dentist in near a clinic, at least will it be helpful to identify those patients?
That is what I was mentioning. That is what we should have done, and that is what was planned by the health department and the IT mission. And unfortunately, like we only made some changes in that, and now we will have to suffer like what has happened.
Exactly. That would have been the ideal way to
Obviously,
tackle it,
like, yeah, I have even the slides with me, how beautifully they have planned. I don't know the method they have adopted. I am not a person to comment on that, but the vision used for that was an excellent idea.
Yes, yes. Dr. Girish Kumar had raised his hands. Are you there, Dr. Girish? You want to raise a question? Oh, I think it was by mistake. Okay.
Yeah, Dr. Anit, can you unmute and talk? You can unmute yourself and talk. No. So it's already 1:45.
Yeah,
Another program at 2:30 and 3:30. So
okay. Then we'll wind up. There is plenty of questions. Anyway, yeah. For the concluding remarks, it was beautiful session, enlightening session. Thank you, Dr. Anoop Kumar. Thank you very much. And for the concluding remarks, may I ask Dr. Deepu to share his conclusive remarks?
No, I wouldn't extend it longer. I'll ask Dr. Faisal to propose the vote of thanks on behalf of everyone. Yeah.
Any panelist wants to add on to it?
No, nothing more than that. It was extensive, elaborate. What else can we say? It was really good.
Okay.
Thanks to Dr. Anoop. Thanks to Dr.
Thanks, Dr. Anoop. It's an excellent, elaborate, informative session. Thank you. Thank you very much.
And to all the panelists also.
Faisal, Faisal ji, vote of thanks.
Yes.
Can you hear me?
Yeah.
Hello.
Yeah, can you hear me?
Yes.
Yeah, go ahead. Yeah.
Thanks to Dr. Anoop for the excellent lecture of the day. And thanks to Dr. Ram Mohan sir, Dr. Anil Kumar sir, Shaji sir for being the panelists for the day. And many thanks to Dr. Dinesh for being the moderator of this CDE program.
Thank you,
I also
Dinesh.
thank Dr. Jayasri Ketty for initiating this COVID-19 program in IDA. And also thanks to Dr. Unni Krishnan for being the technical team who has been with us from 11 o'clock doing all the technical work. And this video will be available in the YouTube. We'll be uploading it very soon. And moreover, we'll be having CDs in the webinar format for quite some time. And every Sunday, we are planning to have a program. So stay tuned with us on every Sunday for State CDE webinar. Thank you, one and all.
We'll have to express our regret for many of the questions couldn't be answered because of these time constraints. So we asked them to go back to the videos on the YouTube and get it cleared if it is there. Otherwise, it's very sorry. We'll have it in some other time because as Dr. said, he's in a hurry and he has some other scheduled meetings also. So anyway, thank you very much, sir. It's been a privilege to have you.
Thank you. Thank you, sir. Thank you.